Okay. Good afternoon, everyone. So today my topic is assessment of impact of
Your
Goldmann.
IOS number, please.
Sir, I'm a member. I'll give you the number.
Okay.
Assessment of impact of Goldmann applanation tonometry on central corneal thickness. So introduction, the most important risk factor for glaucoma is elevated intraocular pressure. Accurate intraocular pressure measurement is essential for disease detection and patient follow-up. So as per the ocular hypertension treatment study, thinner CCT is an independent risk factor for glaucoma and its progression. So according to a study done by Steen et al., thin corneas produce underestimation of IOP up to 4.9 millimeters of mercury, and thick corneas can overestimate it by up to 6.8 millimeters of mercury. So CCT measurement guides us on an aggressiveness of glaucoma treatment and prevent overtreatment. In practice, thus CCT becomes a very important parameter in glaucoma diagnosis and management. This brings us to a very pertinent question, especially when one is seeing general and glaucoma patients both in a busy OPD. Is it logical to insist that all CCT measurements be taken before applanation tonometry? This study aims to find scientific answers to this question. So aim of this study was to assess impact of Goldmann applanation tonometry on central corneal thickness measurement. It was a prospective study conducted over 3 months at Isha Netralaya, Kalyan, Maharashtra. We had used RTView XR100 OCT, and all the IOP measurements were taken on Goldmann's applanation tonometry. We have used paired t-test for statistical analysis. So all patients who presented to our clinic aged between 18 to 75 years were included in the study. And subjects with any corneal disease, intraocular inflammation, corneal scar, poor fixation, and using anti-glaucoma medication for more than 1 month were excluded from the study. So first, all patients underwent central corneal thickness measurement on RTView OCT. This was done by the same trained technician. Within 5 minutes, intraocular pressure was recorded with Goldmann's applanation tonometer after instilling 1 drop of topical anesthetic. All measurements were recorded with the same tonometer on the same slit lamp by the same glaucoma consultant. Patient was instructed to blink normally, and within 5 minutes, central corneal thickness measurement was taken again. So OptoView, RTView, it measures pachymetry by non-contact method. Axial resolution is 5 microns, transverse resolution is 15 microns, and depth resolution is 5 millimeter. It uses diode laser for its laser interferometry. So it takes 70,000 A scans per second, and it has a cornea anterior module which helps in anterior segment imaging by taking 6 millimeter scans of cornea for pachymetric analysis. The high scan speed minimizes the effect of eye movement during data acquisition, which improves the repeatability of pachymetry maps. So our sample size was 60 eyes of 30 subjects. Mean age of the sample was 51.33 years. CCT prior to GAT mean was 498.65, and mean CCT after GAT was 495.18. Mean GAT was 14.7 millimeters of mercury. So after the analysis, we observed that there was a statistical significant difference in the corneal thickness before and after Goldmann applanation tonometry. However, as you can see, that the difference between the two means, that is pre-CCT GAT and post-CCT GAT, pre-GAT and post-GAT is only 3 microns. So a previous study done by Porjovan et al. Reported mean CCT measurement before and after tonometry was 565.22 and 566.04 respectively. This study showed that the sequence of examination of applanation and pachymetry is not important. In another study done by J.W. Branch et al., corneal thickness following tonometry remained stable within 5 microns for 38 out of 43 participants and within 10 microns for all participants. In both of these studies, ultrasonic pachymeter was used. In our study, difference in mean CCT values before and after GAT is in agreement with the previous studies. However, in our study, difference in CCT measurements is statistically significant. We have used OCT. So some believe that CCT measurement that GAT might be influenced by microerosions of the epithelium surface or its desquamation. To the best of our knowledge, no other study has compared pachymetry with non-contact method like OCT before and after GAT. So conclusion, we conclude that for most accurate measurement of CCT using non-contact technique, it is best to do CCT measurement before applanation tonometry. These are my references. Thank you.